Hello, my name is Alexa Barquet. My group members are Bruno Santillán and José Arregui, and today we will present a clinical case that we observed during our hospital rotation at Hospital de los Ceibos under the supervision of our tutor, Dr. Katy Romero. This is a 61 years old mestizo male patient, Presley Villamar, who presents with a chief complaint of worsening headache and blurred vision. According to the history of present illness, he reported a 7-month history of polyuria and polydipsia with an approximated and variable diuresis of up to 11 liters per day along with a one-set progressive headache mixed with amnesia and blurred vision over the past 5 days. Regarding his past medical history, he has a history of a repetitive traumatic brain injury. He denies current medications and allergies. His family history is significant for a mother with diabetes mellitus and multiple maternal relatives with diabetes while his father is deceased to secondary chronic alcoholism. In his social history, the patient lives in Guayaquil in the Flor de Bastion area, works as a teacher, and denies current tobacco and alcohol use. He reports no recent travel, does not perform regular exercise, and follows a diet low in sugar and high in salt. Also, he reports that he have a good family support from his female partner. On physical examination, vital signs were blood pressure 115 over 68 millimeters of mercury, heart rate of 86 beats per minute, oxygen saturation of 96%, respiratory rate of 18 breath per minute, and temperature of 37 degrees Celsius. On inspection, the patient was cooperative with tired facies, Glasgow Coma Scale 15 out of 15. He was normocephalic, no tibial edema, with peripheral venous access in the left arm vein. Also, preserved thoracic expansion on ventilation and in on percussion, findings were preserved. On palpation, there were no palpable cervical lymph nodes and no pain on abdominal palpation. And on auscultation, heart rate was within normal limits with regular rhythm and no non-abnormal sounds. Lungs were clear, bilateral with good ventilation and no abnormal sounds, and the bowel sounds were normal. Based on these findings, the presumptive diagnosis is central diabetes insipidus, um, secondary to an intracranial lesion, most likely a pituitary mass, as we think.
Now, regarding the lab tests of this patient, first, a complete blood count was done on the 20th that revealed no abnormal changes, normal white blood cell count, normal hemoglobin, hematocrit, normal mean corpuscular volume, etc. The patient was admitted with some previous lab tests done on the 19th that revealed hypernatremia of 147.8 and low calcium levels. Now, some other uh, sample taken on the 23rd revealed hyponatremia, which is not a common finding in central diabetes insipidus, a hyponatremia of 117.4 and also hypochloremia of 89.8. The urine electrolytes were diluted in a sample taken in the 19th, low urine sodium, low urine potassium, low urine urea. In the 19th, there were also some samples taken to assess the urine and plasma osmolality. The urine osmolality was borderline low at 812, and the plasma was high. Osmolarity was high at 304. Also, the patient had some hepatic, pancreatic, lipid, and renal tests done that revealed normal hepatic enzyme levels, normal pancreatic enzyme levels, normal fasting glucose, but elevated total cholesterol at 303, elevated LDL at 169, and low HDL at 85. But urea, uric acid, and creatinine was normal regarding the renal test or the renal function. Now, this patient had a D-dimer of 2.8 in the 19th, on February 19th, that suggests the patient may have had a thrombotic process going on. And in the endocrine panel, there were some samples taken on the 19th, but also on the 23rd. On the 19th, the patient had an ACTH of under 5, which is almost suppressed, a dehydroepiandrosterone of 12, which is low, serum prolactin normal, normal TSH, normal free testosterone, but low cortisol at 0.4, and normal IGF-1 at 66. Now, finally, regarding microbiology tests, a urine culture taken on the 22nd came back as negative.
So now we are going in this case presentation to talk about the management and the conclusion of the patient. So this patient was treated with dextrose at 5%, 1 liter at 180 milliliters per hour IV. For the dehydration the patient presented, the dose of acetaminophen IV. For the headaches the patient presented, and desmopressin peros. And we are going to explain this later. So, the patient was interconsulted with neurosurgery, and as we discussed, the patient presented an intracranial lesion causing central diabetes insipidus, with symptomatic treatment being a vasopressin analog such as desmopressin. Because this is an analog of the ADH, it will directly counteract the physiopathological mechanisms of this disease. So regarding the imaging, the patient presented with a CT scan of abdomen and thorax that was unremarkable, and the brain MRI was ordered. But when we did the examination, we didn't have access to it. So in conclusion, for this case, this patient who's 61 years old, currently assessed for central diabetes insipidus, secondary for a probably central lesion, most likely a pituitary mass under investigation because of the compression symptoms the patient had, such as the blurred vision or the headaches. He had conscious he was conscious, but he had mild memory loss. Sometimes he was a little disoriented. He was tired, had persistent headache and blurred vision. The neurologic symptoms are probably because of the uh, hydroelectrolytic disturbances because of the IDH lack, and he had a controlled diuresis of 6 liters per day. As a comment, we have that the CT scan that we already mentioned was ordered, but nothing remarkable on the thorax or abdomen. But in the brain MRI that it wasn't already available, and we are assuming that we could see the pituitary lesion because of the symptomatic and clinical presentation of this patient. and then we should have another treatment to have a definitive treatment for this patient.